Hi, everyone. This week's discussion post is on left-sided heart failure. Left-sided heart failure is also referred to as congestive heart failure, CHF, which I'm sure you've heard of. It's a condition that occurs when the heart is insufficiently functioning as a pump to meet the body's demands. CHF is typically a result of another medical condition, such as a previous MI, hypertension, left ventricle dysfunction, aortic or mitral valve dysfunction, obstruction, vessel disease, or cardiomyopathy. The sympathetic nervous system, antidiuretic hormone, and renin-angiotensin-aldosterone system respond to the malfunctioning of the heart in an attempt to maintain adequate perfusion of the body's organs. To compensate, the heart's contractility is increased, diastolic pressure is increased, and there's an increase in a LV afterload. The compensatory mechanisms ultimately lead to an increased pressure in the pulmonary and venous circulations, which leads to the pulmonary congestion and significant lower extremity edema that we see in a clinical setting. Patients who are at risk for left-sided heart failure are patients with a history of hypertension, coronary artery disease, infarction of the left ventricle, aortic stenosis, a history of cigarette smoking, diabetes, and obesity. The major signs and symptoms of left-sided heart failure: fatigue, weakness, dyspnea, exercise intolerance, and cold intolerance. Some signs and symptoms that you will see clinically that show the patient is compensating is tachycardia, pallor, secondary polycythemia, and daytime oliguria. Further signs of compensation that demonstrates that the body's attempts to compensate have failed include orthopnea, a cough that produces white or pink tinge phlegm, paroxysmal nocturnal dyspnea, hemoptysis, and rales. You can see here in the picture that this man is trying to exercise and he's profusely diaphoretic. He's got some swelling in his lower feet. His lungs are full and he's having some difficulty breathing just with a small task. Left-sided heart failure is diagnosed largely in clinical picture, which includes the presence of the dyspnea, fatigue, and fluid retention that we had talked about. Diagnostic testing includes a chest X-ray that will demonstrate cardiomegaly or a pleural effusion. An EKG will likely demonstrate left atrial enlargement, LV hypertrophy, atrial fibrillation, or Q waves. And laboratory testing of serum natriuretic peptides will likely demonstrate an age-adjusted elevation in BNP of greater than 100. Heart failure can be classified as heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. This diagnosis is based on the EF, which is measured by the echocardiogram. A reduced ejection fraction is an EF of less than 50, and an EF of less than 40 is considered profoundly low. These are my references. I hope this is helpful. Thanks.